Uh, Good morning. I can't thank you, the DEOS board, the SWORD board, for inviting me. My talk will be very easy one, not lots of science in it. So I'll talk about the management of resistant infectious corneal ulcer and the cases of the case that we see all the time in our clinic of an 18-year-old lady with a history of post-contact lens cornea infection. She went and visited many doctors, and she had more than 5 months of receiving all known topical antimicrobial, anti-acanthamiba, antiviral. So everybody is trying whatever he think it is. So when she came, this was the picture with, we have this deep stromal abscess, and we have on the other side a highly vascularized healing part of the ulcer, which is very angry eye. So what to do here, the plan of management, either to keep on trying the medical treatment, but this will delay your decision for keratoplasty with loss of vascularization, which can jeopardize your graft, or to go for an immediate therapeutic graft, which is a little bit risky because the infection is still there. It is hidden in the trabecular meshwork, and you can have a repeated infection of your graft or others. So you have to weigh your risk against the benefits. And here, this paper, Namrata, she presented the TST, topical systemic and targeted therapy protocol, where she will start with, so for me this was, because we took a scrap of the ulcer and it didn't show any growth, and for after the history and clinically I thought more of a fungal infection. So again, this TST protocol, you start with enatamycin, and in steps of 7 to 10 days you add the fluoroconazole. Then if it doesn't work, you have a choice of what we did, this intrastromal or intracameral antifungal infection. So I thought of giving an intrastromal voriconazole on the area where the infection is florid, and to give a low dose of steroids on the area where the vascularization was present and the eye was angry, to help alleviating this inflammation. So this is what we did. First, we scrapped the surface to take some specimen for more lab tests and to decrease the brunt of the infection. And then with a 25 syringe, you go from the healthy cornea at the edge of the ulcer, and you inject until you have this blanching, and you go all through all over the ulcer all around, and you take care of thinned area, not to perforate. And even if you perforate, the concentration of the medication we are using is the same one of the intracameral injection. So as you see, we go all around, and the end point will be the blanching that you see. And then we injected a small amount of dexamethasone, and 3 weeks later, this is the picture of complete resolution of the abscess and the subsiding of the vascularization, and the eye became that quiet. So this may be the proper timing to go for a keratoplasty, because this was an 18-year-old girl with this whitish discoloration of the cornea, and the keratoplasty is the normal one. You do a PKP, you do a big one graft, so you can remove all the parts where the abscess was, fearing of some residual infection. And you can wash. You have a wash with fluconazole, and then you do your stitches as usual. And 1 month later, this was the picture. We have good results of uncorrected visual acuity of 0.8. 3 months later, this was the picture of this young girl that had an agony for 5 months. So we will put a spotlight on the intrastromal voriconazole injection. We all know that the fungal ulcer involves the deep stroma, and you have to use the medication, which is a large molecule that have poor penetration and can cause toxicity, and toxicity can cause delay healing of the surface of the eye. So targeted or direct drug delivery in the form of intrastromal injection is more potent and overcomes the epithelial toxicity of the prolonged topical treatment. And we all know the antifungal medication that we have on the market, but the voriconazole seems to be the most potent one. So this is the types of medication that we have. Not all of them are used in ophthalmology, but we know the fluconazole, the diflucan, and the voriconazole, the Vifend. So how to prepare this injection, the intrastromal one? This is how it works. It is again the spectrum of the voriconazole. It is against Candida, Aspergillus, Fusarium, and it has proven an efficacy against Acanthamoeba. That's why I chose to use this medication in this contact lens wearing young lady. So this is how you prepare it. You take a 10-20 milliliter distilled water added to the powder, and this is how you prepare the drops. Then you take 1 milliliter of the drug that you prepared, and you put on it 20 milliliter of distilled water, and you have a 0.05% concentration that you can use. When will you go for this intrastromal injection? When there is a poor response to topical natamycin and voriconazole, plus or minus iatropax, systemic medication for a maximum of 20 days, and there is no perforation or impending perforation in the patient. And again, this is how you go. You go from the green part where the healthy cornea, at the edge of the yellow part where the abscess begins, and you take care of the stained area, and the drug is injected in amount of hydration of the cornea, as we also this blanching of the stroma of the cornea. So the take-home message will be, in treating deep resistant fungal and mixed corneal infection like this young girl, think about all your weapons. Targeted injection of voriconazole is safe and effective, and the timing of therapeutic penetrating keratoplasty is very crucial. Not too early, so you'll have another infection in the graft, or not too late, so you will have maximum vascularization and rejection. And low-dose steroids under the umbrella of antifungal is beneficial to suppress the inflammation and neovascularization before therapeutic keratoplasty. And this is what we learned from the endophthalmitis, because our colleagues, retinal specialists, in case of endophthalmitis, they will inject intravitreal antibiotics and steroids. So I thank you very much.